at Chesterfield.
Thanks, Luke. Just to explain, Luke's in the office at the minute. I'm in the office, but I have my own office, and Luke's in a shared office, so he's having to wear his mask at the minute, which is usual practice now within the offices in the NHS. I'm just going to share my screen then, and then we will take you through the presentation, which hopefully you've already seen. So we've done introductions. So the things that we're going to talk about today are how we are redesigning our hospital outpatient services across the whole joined-up care Derbyshire system. So this is all the acute providers that you would go in to see. So Derbyshire Community Health Services, Chesterfield Royal Hospital, University Hospital of Derby at both their sites at Derby and Burton. So we're changing outpatient services across the system. And we're doing a number of things, but we want to talk to you today about 3 priority areas. One of those is GP advice and guidance, which means that you might not need to attend a hospital to actually see a consultant, and we might be able to give advice to your GP. The second is non-face-to-face outpatient appointments, so that you might see and talk to a hospital consultant or another clinician, but not via a face-to-face appointment. That might be via telephone or video. And then also around patient-initiated follow-up, which means that we put you in charge of accessing our hospital services when and if you need to. So just to give a little bit of context, the things that we're working on around outpatients change were priorities that were set nationally in the NHS long-term plan that was published back in 2019. So they were saying in the long-term plan that over the next 5 years from 2019, the ambition was to avoid up to 1/3 of unnecessary face-to-face outpatient appointment visits, and that we would do this through giving patients control and convenience in hospital services. So we would do the things that I've already talked about, that we're going to talk about today. So working with primary care and GPs to avoid the need for people to come into hospital, offering telephone or video consultations, or empowering people to book their own follow-up. So what we're doing in Joined Up Care Derbyshire is absolutely aligned with the national long-term plan, and we were doing these things prior to the COVID-19 impact, which kind of hit us really from March last year. COVID has changed how we're doing those things. We've had to accelerate and go quicker with some of those changes. The chart that you can see in front of you shows outpatient appointments delivered via telephone at Chesterfield Royal Hospital, and you can see here we were delivering around 4% of our appointments via telephone prior to COVID. COVID hit, and then over the first 4 weeks of COVID, we moved to 86% of telephone of outpatient appointments being delivered via telephone, and that was really to ensure that we could continue to talk to our patients and continue to see people, because we weren't able to see people in a hospital setting. So COVID-19's changed, but the majority of what it's done is really accelerate and move us forwards. So the benefits of that change and what we're hoping to see: less time for patients travelling to hospital and sitting in waiting rooms, better access to hospital when people really need it. We've definitely got a new one in there around supporting recovery of services in response to COVID-19, but also the impact on the environmental impacts and reducing the NHS's carbon footprint and contribution to congestion across the roads. So the measures at the bottom are things that we are calculating now to demonstrate the benefits of outpatient change across the Joined Up Care Derbyshire system, but also nationally for the NHS. So if I go into the first area, which is GP advice and guidance, and just talk you through in a little bit more detail exactly what that means. So advice and guidance is providing a primary care GP with access to advice and a conversation really with a clinician in a secondary care hospital. So that means that what we can do is hopefully manage the patient in the most appropriate setting, have a shared conversation and shared decision making about what that patient needs, and hopefully avoid anyone coming into hospital who doesn't need to be there. Reasons why your GP might wish to get advice and guidance include just asking for general advice on what the next steps would be for that patient, clarifying a patient's test results, getting advice from a secondary care clinician on would it be appropriate for this patient to be seen in a hospital setting, or also identifying the most clinically appropriate service to refer the patient into. That can be a real issue in primary care. There are lots of clinics, lots of clinicians in the hospital, so getting the patient into the right place in the hospital if they need to be there is really important for us. So the benefits for hopefully you and the patients are being managed in the community where it's possible to do that, getting rapid advice and reassurance. Sometimes there are longer waits to get into hospital for an appointment, whereas if the advice and guidance can be given, you don't need to be there, you can be rapidly reassured and advised about what the next steps need to be. That means we can ensure that all the capacity in the hospital is used effectively, and the patients who really need to be seen can be seen as quickly as possible. We can give advice about diagnostic tests that are required before the appointment booked. Really, really important, because we want to make sure that when you see the hospital consultant or clinician for the very first time, you've had the appropriate diagnostics in advance, and that consultant or clinician can make a decision about what needs to happen next. As I said before, referrals can be channeled into the correct clinic, and you don't end up with duplicate appointments because you weren't referred into the right place first time. And the most important thing is that that first appointment in hospital is value added, in the right place, with the right clinician, and with the right information to take the next steps and decisions about what happens next for the patient pathway. We've taken advice and guidance a little bit further at Chesterfield Royal. So one of the things we did during COVID-19 was clinically triage all the referrals that were coming in. So a consultant or another clinician would look at every single referral and make sure that that patient, if clinically urgent, was still being seen. We were still bringing them into the hospital setting if appropriate. That proved really successful. We got a lot of learning from that about the benefits of patients getting into the right slots with the right clinicians as urgently as they needed to. So we've now put that into place fully at Chesterfield Royal Hospital. So it's called a Referral Assessment Service, or a RAS. And what that means is when you are sitting with your GP in primary care, you won't automatically get booked into a clinic slot. The GP will make the referral, the consultant or clinician in hospital will look at that, and then they will decide what's the most appropriate next action for the patient. So that could be advice and guidance back to the GP. We might decide that a straight to diagnostic test is right first, or the consultant or clinician can then make a decision about if they do need to see the patient. Is it a telephone consultation? Is it a video consultation? Or is it a face-to-face? Where's the right place to see that patient? And that's been so successful that we're now piloting that RAS service in university hospitals, Derby and Burton as well. I'll hand over to Luke, who's just going to talk you through non-face-to-face outpatients.
Hello, thank you, Maria. And I just noticed in the chat we've got some questions around kind of additional strain on the initiatives that we're doing, and I was about to type an answer, but I just thought I could kind of answer just now. It was regarding so if we have we do acknowledge that we might have kind of additional strain or pressure on the system while we're implementing these initiatives. However, by hopefully getting the kind of the right care by the right clinician in the right location, that will then overall reduce the strain further down the line and reduce kind of the impact on clinicians. So just to answer that, but now I'll go on to kind of non-face-to-face appointments. So if you can just go on to the next slide, please. So outpatient hospital visits have doubled over the last decade. And unfortunately, we still see kind of 1 in 5 appointments are either cancelled or patients do not attend the appointment. And obviously, this tells us something about whether we're truly adding value with each of these appointments. The model that we've got can be inconvenient, so it can be inflexible. You know, people have to take time off work, arrange childcare, and travel to and from hospital appointments. And it might not be the kind of the best use of their time, considering the appointment might be 10 minutes, but the journey times, etc., can be a lot longer. And as Maria mentioned, kind of the long-term plan was set out to reduce the number of face-to-face outpatient appointments. However, what I'm going to go on to explain is that we've kind of dramatically achieved this kind of really quickly due to the COVID pandemic. And just to add in again, following on from what Maria said in the introductory slides, that we have to consider kind of the environmental impact of travelling to and from the hospital. Now, obviously, if we are offering virtual appointments, not only does that mean that patients may not have to travel to the hospital, but if we've got kind of virtual working conditions for staff, then they may not also travel to and from the hospital as well. So Maria, next slide, please. So this this slide here really demonstrates the impact that COVID-19 had on that transition from kind of face-to-face appointments to non-face-to-face appointments. So March 2020, 3% of the hospital outpatient appointments were delivered through non-face-to-face models. So that's kind of telephone and video, like we've mentioned. Fast forward to March 2021, and around 40% of our hospital outpatient appointments were being delivered virtually. So that's a huge increase, and it was fantastic that we achieved such an increase in such a short space of time. But we also do acknowledge that not all appointments can be delivered virtually. So just to kind of reassure people that we're not kind of forcing this if it's not appropriate. Next slide again, please, Maria. So when we talk about, like I said, when we talk about non-face-to-face appointments, we might be looking at telephone or video. And at the minute, we're trying to increase the use of video consultations and offer patient choice whether they would prefer this over a telephone. And the reason we're doing this is because we've had kind of really good feedback about video appointments, which I will go on to shortly. So we're seeking to find kind of new and innovative ways of using the video consultations. And on the screen, we've got a few examples about where this might be, and I'll read them out because I think some people are struggling with slides. So we've got kind of assessment for symptoms of movement disorders, demonstration of relaxation techniques, swallowing assessments for speech and language therapy services, and that's in both adults and children. Support with insulin pumps within diabetes services, and then also group clinics for physiotherapy services as well. And I guess as a clinician, so I work as a physiotherapist myself as well, and I've used the video appointments to do a joint approach with some community clinicians as well. So that's involved kind of a nurse in the patient's house, dialing me in as the physio, and we can kind of do a joint consultation without the patient needing to come to the hospital site, which worked well. So just at the bottom of this slide as well, we've got a link where you can access some videos with a bit more information about the virtual consultations. So I think they've been sent out previously, so it would be worth having a look at those videos if you haven't already. Next slide, please. So like I said, we were going to just go into some patient feedback now as well. So kind of what do our patients say about the video consultations? Well, 97% have said that they would have another video appointment, which is fantastic. 90% report their experience as being very good or good, which again we're really happy with. Then 78% saved up to 2 hours compared with a face-to-face appointment. So again, that's the travelling time, the parking time, and everything associated with visiting the hospital. And then 75% of people asked saved up to £15 compared with a face-to-face appointment. So again, thinking about kind of the cost of attending a hospital appointment with travel costs, parking, there's lots that add into it, time off work. So saving money is obviously beneficial for the patient as well. And then there's also kind of reporting of key benefits, such as not having to take time off work, like we've said, arranging childcare, and actually delivering care in patients' homes where they feel comfortable as well, which is great. Next slide, please. And then coming back to the kind of the first point on one of the slides, which we were talking about, kind of the number of appointments that are cancelled. And this chart that you can see on the screen at the minute, it just shows that kind of we had the number of cancellations has significantly dropped since we've been doing more virtual ways of working. So that might mean that the patient might not be able to attend the hospital appointment, or maybe not feel comfortable during the current pandemic. but by doing virtual appointments, we've then continued with more activity and consequently seen more patients, which again is fantastic for both staff and patients. And that's it, I think.
Thank you, Luke. So I'm just going to talk to you about the third initiative, which is patient-initiated follow-up. So patient-initiated follow-up means when a patient or a carer can initiate follow-up appointments as and when they're needed. So when you've got a symptom or a flare-up or circumstances change, and it's a key priority. It was a priority prior to COVID-19, but it's a key priority as part of the NHS COVID-19 recovery to make sure that we are utilising our capacity for the patients who actually need to be seen. You might have heard it used previously. There's lots of different things it's been called previously: open access, patient-led follow-up. What we're really focused on, all of those different ways of describing it there were slightly different things with slightly different ways of working. What we're focused on in Joined Up Care Derbyshire at the minute is having one way of doing patient-initiated follow-up, one process, one terminology for it, so that we can ensure that our patients and public understand what that means in Joined Up Care Derbyshire, and we all across the various hospitals, whether that's Chesterfield, Royal, Derby, Burton, or it's a community hospital, we all operate in one single way of doing it. So the benefits are avoiding unnecessary trips to hospital, helping people take control of their own health care, giving you an option to have an appointment when you really need it, and then helping to reduce the pressure on services because we're effectively using our capacity. So it's around personalisation, clinically led, and really intended to deliver high quality care. So patient feedback, we've been looking at both nationally and locally within the Joined Up Care Derbyshire system. So patients have been generally supportive, as it's seen to be a more proactive and efficient system, with people liking flexibility. So a couple of areas where there's been particular positive focus are around patient empowerment and trust, that people feel like it's giving them confidence to be in control and manage their own conditions. People like the flexibility that it allows in terms of enabling you to speak to somebody in secondary care in a hospital when you feel like you really need to. Similar to the non-face-to-face appointments, saving you time and describing that it kind of you access a hospital appointment when it feels that it's adding value and you're not having unnecessary appointments. And then again, saving appointments for the people who most need them. So people were really positive about that, reflecting on the current capacity problems that we've got across healthcare at the moment. So not everything's positive, and there are concerns which we've really sought to address in how we do patient-initiated follow-up in Joined Up Care Derbyshire. So continuity of care is really, really important. People don't want to explain their condition to a new person every time they contact the service, and that wouldn't be the case. It would be the same consultant care that you would have through a patient-initiated follow-up appointment. Communication, really, really important. So our patients have to understand the process and understand how and when to initiate an appointment. And also have the confidence that it's okay to do that, not worry about doing that. So we've really focused on the communication, the patient information side of things. It's obviously not appropriate for all patients, and we're really focused as well on ensuring that we, in applying this approach, that we recognise some patients are vulnerable, some patients wouldn't be able to follow a patient-initiated follow-up process. So making sure that we only put patients who are appropriate onto this pathway. The hospital processes really need to be clear, run smoothly. You need to be able to re-access the service really easily when you need to. Services need to have the capacity to see you when you make contact. And one of the things we're doing in Joined Up Care Derbyshire is not only monitoring the number of patients who go onto a pathway, we're monitoring the time to re-access. So if you make a patient-initiated follow-up request and want an appointment, we're monitoring how long it takes for you to get that appointment and making sure that there aren't any delays when you're accessing an appointment through a patient-initiated follow-up pathway. And then standardisation across the system. As I've said, we want one way of working for patients so that you all understand what patient-initiated follow-up means and you have a similar way of processing and reaccessing services across the whole Joined Up Care Derbyshire system. The other thing that's really important is that this is only used within appropriate services. It's not suitable for every service. So what we're really focused on is the pathways and conditions where follow-ups are done on a regular basis. So you have a regular 3 or 6 monthly update, and they tend to be kind of the long-term conditions that people experience. So what we want to have is that you don't have a routine 3 or 6 month appointment when actually you're feeling really well. What we want you to be able to do is reaccess when your condition deteriorates or changes, so you can see the clinical team when you really need to. And that might not be, you know, it might be 4 months you need to see a clinician, then we don't want you to wait another 2 months until your follow-up appointment. We want you to be able to access at the 4 month point that you actually really need to. So services where we're currently using or actively seeking to increase the use are pain management, dermatology, rheumatology, diabetes. They're just a few of the areas, but they're areas where patients have those regular follow-ups, and we recognise that those follow-ups might not be at the right times for the patient. So that was all I was going to say in terms of the slide set. Thank you for listening to us. What we've deliberately done here is take you through the slides really quickly because we want to kind of leave lots of time for a dialogue with you. We did send out some questions, I think, so we really want to get your thoughts on all of those initiatives. I think whilst they are national things, that are national priorities, we're really focused in Joined Up Care Derbyshire on delivering those in the right way, and there is opportunity to influence how we do it in Joined Up Care Derbyshire. We really recognise that not every healthcare system is the same. Patients are different in Derbyshire than they are in London, and we want to have the right approach in Derbyshire that works for our patients here. So there's absolutely opportunity to reflect your thoughts and to influence the future of our work programme. Just to say that whilst I was sharing my screen, I couldn't see any of the comments. So hopefully Katie and Miriam can help me in terms of feeding back questions. But just so you know, I wouldn't have seen any comments or questions that you've put in previously.
Nope. You've already answered some of them, Maria, and Luke's already answered one as well. One of them was around, is this a Derbyshire-wide initiative, which it is, not just for Chesterfield. And another one was, do the people who are involved today and in the long term have an opportunity to influence some of the work? You've answered that. I think you've partly answered Pete's as well, which was with respect to follow-up appointments. Will the patient have to initiate by contacting their initial point of contact, for example, the GP, or will the patient be able to organise their own follow-up directly with the clinical team?
Yep, so we wouldn't want you to reaccess through your GP. We think that's not great use of time for a GP. What would happen is when you leave the hospital setting and we put you onto one of those pathways, you would leave with a letter explaining that, you would leave with information about a patient-initiated follow-up pathway, and you would leave with all the details about reaccessing that pathway, who to call, how to make the appointment, and all of that. So you would absolutely be in control of making that appointment yourself. We would, however, also copy that to your GP, so your GP would know on record as well that you were on a patient-initiated follow-up pathway, and could support you if you went to your GP around something else, or if you did contact your GP, it wouldn't be a problem. Your GP would be able to see that, but it definitely, we wouldn't want to waste GP's time by you having to go there first before you saw us.
We've also had a question, I'm sorry if I've pronounced it, is it Jose has asked, where does patient choice come into this, as it feels like it could be sort of commodified or dehumanised?
So we absolutely recognise with all of the initiatives that we've just talked about that patient choice comes front and centre of them all, and we're really focused on that throughout all the programmes. So, for example, when Luke talked to you about non-face-to-face, we want to have as much choice as we can offer within the type of appointment that you have. So if you would prefer a video appointment, we're really focused on you being able to have that offer and being able to access it should you need to. We're really focused with the patient-initiated follow-up on that shared decision-making. We would always have a conversation with a patient about putting them on a patient-initiated follow-up pathway, and that really would be a shared conversation and a shared decision. It wouldn't happen to patients. It would be a shared conversation, and absolutely patient choice comes front and centre.
And Luke, Val's asked, what about patients with no access to IT for online appointments?
So again, similar to what Maria said, if people don't have the equipment or have access to IT, then absolutely we can offer face-to-face appointments. So absolutely, and I still always kind of the approach I always think when working clinically is, am I offering a service that I would want to offer my family members? And again, I've got lots of family members who couldn't access appointments using IT, and absolutely I would want them to come and have a face-to-face appointment. So yeah, no IT, we can still see.
And Luke, I think because you talked about the survey results, Pete said, do you have any feedback results from those people who experience non-face-to-face consultations? So you've talked about the people who used video, but have you got any experience of people accessing it using the traditional methods?
So we do normally collect feedback with the traditional methods, and that's one of the pieces of work that we're currently working with our patient experience team at the minute, to start trying to more comparisons between them, really. So how can we compare between face-to-face and non-face-to-face? The initial kind of built into our system for the video appointments, because it was an NHS created system, it was already there ready to start collecting feedback. So that's why it was so easy to access. But we are having regular conversations with the patient experience team on how we can kind of work both ways for the face-to-face appointments as well.
Thank you very much. Maria, another Peter, there are quite a few Peters, don't Peter to think it's all him. It says during the drop from 3% to 40% of face-to-face between the two marches, did you notice any drop in diagnosis accuracy?
Absolutely
or diagnosis?
No, I mean, I think from our clinicians' perspective, they are really happy with that shift. You will see that in terms of the long-term plan ambitions, there was lots of work done before the long-term plan was published nationally to look at the value of some of the outpatient appointments that were happening. And there was a really clear evidence base within the data that not all of those outpatient appointments were needed. Patients were being put on really extended follow-up pathways, and just going back in to see a hospital consultant to have a 5-minute conversation to say nothing's changed and I don't need to be seen. So there's a really good evidence base that we weren't seeing value across all of the outpatient appointments that needed to happen. So when I talk about the referral assessment service in advice and guidance, and the fact that the clinicians up front make a decision about the referral in and make a clinical decision, does that patient need to be seen right now? Could they have a diagnostic? Do I need to see them face to face via video or via telephone? That's actually been proven over the COVID response to improve, and that's one of the reasons why we've extended it, because what the clinician is doing is the patient is not sitting on a waiting list waiting to come in for an outpatient appointment for weeks and weeks. The clinician is within usually in less than 7 days from the referral, looking at that referral and making a clinical decision about, I need to see that patient really quickly, or actually I think that patient should be managed in primary care or community care, and these will be the next steps I would do on that treatment. So I would say it's improved because we're making clinical decisions much earlier in the patient pathway once the referral has been made from primary care.
Lovely, thank you. We've got another, there are some comments in there. I don't think they were questions, so I'm terribly sorry if I missed it, if I've missed one, but I've gone to Louise, who asked, the stats look great for hospitals, but are there concerns that during the pandemic people didn't go to the GP, so they've become uncomfortable about being seen in the traditional way? And does it mean that people could get missed?
Yeah, so nationally we recognise that patients have not attended to see their GP in the way that they would have usually done over previous years, and also GPs have been operating in different ways as well, with lots of remote consultations in the same way we've been doing. So we recognise that patients on an ongoing basis and for a significant period for the future will need reassurance. We do want you to access healthcare. We do want you to access your GP. Please don't be worried about doing that. But we recognise there will have been a cohort of patients who won't have gone and may still be worried about doing so. So we're really focused in Joined Up Care Derbyshire on how we encourage those patients to go and see their GP and to initiate their patient pathway and get them into a hospital service as quickly as we can when they need to be.
Luke, Madison's asked a question. Madison, you may wish to unmute your microphone and ask it, but I think it's saying, how are you dealing with patients and clients who you're having difficulty engaging with?
Yeah, so this is in relation to when there might be safeguarding concerns in relation to a particular patient or client, and was not brought is also what was traditionally called did not attend. Just wondered what sort of safeguards you've got in place to deal with that type of problem.
Thank you. So when we were working up the processes for this, we were going around that conversation you've just mentioned, and one of the things that we have said is the processes predominantly remain the same as before. So if we have a patient who was not attending or who was not being brought to their appointment, then the same safeguarding processes would be followed. In addition to that, what we have found is then we provided guidance to talk about the suitability of patients for virtual appointments. So if we have patients who are particularly vulnerable, then the clinician can make the decision that actually this needs to be a face-to-face appointment as well. So that is there. But what we did say is if we had a vulnerable patient who was not attended or not being brought, then the same policies, the same process will be followed.
Thank you very much. Thank you.
There was another one, Luke, you might want to pick up. It just said this, obviously this could be great from a sort of administrative organisational perspective, but maybe it isn't psychologically. Yeah,
and we do recognise that. So again, we've kind of transitioned in this space now where everything's over this type of format, video and telephone, and we do recognise that we do need some human contact as well. So again, going back to where Maria mentioned that it's about patient choice and what patients would like. So if they want the face-to-face contact, then that is available. But obviously, it's making sure that we use kind of resources appropriately as well.
Thank you very much. Sanjay, I know you wanted to ask a question. You've raised your hand. Would you like to unmute your microphone and ask the question?
Yes, can you hear me?
Yes, we can.
Okay, basically, I've heard from someone that outpatient appointments and surgical procedures are never booked in school holidays. Now, for the past 50 years, me and my children, we've never had a school holiday appointment. And if that is the case, why discriminate?
So I can come back in on that. That's absolutely not the case. What we might have is a little bit less capacity operating during a school holiday, because obviously a lot of our staff are parents as well and want to take time off. But we, across all of the hospitals, across all of secondary care, we manage the capacity so that the services keep operating. If you were in a particular specialty area, only a certain number of people would be allowed to be off on leave at the same time, and that would be balanced in the area based on still delivering the services. So I've come out of a conversation this morning where we were planning for the Easter holidays, and we've put additional, the consultants and the clinicians who are here are putting additional clinics on so that we can still see the patients, so that covers for the patient, for the clinicians who are off with their children next week. So that's absolutely not the case. None of the services ever across any of the hospitals would completely stop. That just wouldn't be the right thing to do for our patients.
Thank you, Maria. There's a question from Anne as well. Would you like to unmute your microphone, Anne?
Sorry, I just had a quick question before. Is it okay? Sorry.
Yes.
Okay,
yes.
sorry. Over the past 2 years, with my GP in particular, they've had telephone triage for a number of years now, and it's harder to get an appointment on the phone. Let me give you an example. My wife works full time at work, and she doesn't have the time to answer the telephone call. So I'm a third party, and obviously they can't talk to me because of confidentiality. So there's a barrier there, unfortunately.
So I'm not completely familiar with primary care processes, and we're really focused on the hospital side of things. But absolutely, patients seeing GPs have been offered telephone appointments, and I'd probably need to go in and do a little bit more detail and a bit more digging from the programme leading primary care to find out about some of the improvements they were trying to make around the front end into GP practices.
Thank you very much. Anne, I know you have your hand raised.
Yes.
Did you want to ask a question?
Thank you very much. Please, 2 things. I happen personally to be extremely deaf, and so a video consultation is a great help. But while we do our best on our side, unfortunately, Maria's line is badly acoustically affected, which makes her quite difficult to understand. And Luke is using a mask, which, though I don't totally lip read, is also a big difficulty as far as people who are deaf are concerned. I think these are things that need to be, if you want to make people go for video calls, then you have to be careful that your side of the goings on are as good as they can be. I am also pushing as hard as I can because I have 30 years chaired deaf and hearing support in Derbyshire, and we are trying to get people to use transparent face masks wherever they are suitable. It is an enormous help. Thank you very much.
Thank you, Anne. I do apologise if you've had any problems with my line, and again, apologies, but Luke is working in an open office at Chesterfield Royal today, and infection control procedures mean that if we're working alongside colleagues in an office now, we have to wear a mask in the hospital, so apologies for that, but we will reflect that in future, and what we'll try to do for future sessions is find Luke a place to sit where he can sit without his mask on. So thank you for the feedback on that. Just in terms of the deaf community, that's actually been a real focus for us in our outpatients programme this year. We've focused on making sure that we've got appropriate access, and we've put some specific things in place. Luke, did you want to talk about some? I'm conscious though that whether Anne can. Perhaps we write something up about some of the things we've done for the deaf community, and we give that to Miriam to pass to you and comment on, and that might be the best thing to do.
Right, we've also had a question from Val saying, how long is there a time limit on how long the patient-initiated follow-up would last for? And how can you ensure there's sufficient clinic capacity to see all the patients who might wish to use it?
Yep, so there will be a time limit, and that won't be a one-size-fits-all. It will be decided between the clinician and the patient what's appropriate. And normally it would follow the pattern that it would have done if you were accessing face-to-face. So if in the past we would have said, okay, we need to see you at 3 monthly intervals for another year, the patient-initiated follow-up pathway will be you can re-access at any point within the next year, and it would have followed the pathway that you would have been previously on. Sorry, remind me what the second part of the question was, Katie.
It was about clinic capacity to cover that, but I think you've touched on that as well.
Yep, so we are actively monitoring how many patients are asking to re-access, and then we're monitoring the waiting times. So just like if there was a face-to-face need, we look at our clinic capacity every single week, and if we've got a waiting list growing, we put extra capacity on. So we would manage it exactly the same way as if it was a face-to-face appointment coming through a normal route, and make sure that we had that we put extra capacity on where we needed to, and that we're really focused on those wait times for re-access on a patient-initiated follow-up pathway should be less than they would have been if you were coming through a normal route, and we've got an active eye on that data.
Just to say that along with people with auditory impairment, there's also been a question around how does it impact on people with sensory loss as well. So perhaps we could answer both those together, Maria, when we send out the full answer around people for the deaf community. Would that be okay?
Absolutely, we can cover that together. Yeah.
And then another, Pete's also asked, how do we make sure patients have got the confidence to initiate access into the service?
Yeah, so that's really about having that really good conversation before you access that pathway. We're really focused on working with all of our clinicians, and they all have our patients' best interests at heart, and wouldn't want to put anyone onto the pathway if they didn't feel like that they had the confidence to manage. So it's a combination of a really good conversation between the patient and the clinician or consultant, and good information. So we want you to have all of that information that you can re-access. We are putting that information, as well as giving it to you when you would leave the hospital. We've got information in terms of the trust websites, and as I say, that information would also be with your GP. So we're trying to give as much confidence through as many routes as we can. But if you have ideas for how we could improve patient confidence to do that, please let us know, and we'd be happy to work with those.
Thank you. We've had a question from Lisa saying, are the approaches, the approach to the three elements being rolled out across all the providers in a systematic way? So the same pathways being redesigned at the same time in all the hospitals?
Yes, so these are national initiatives, so we're looking to implement them in Joined Up Care Derbyshire across all of the trusts. But what we're also doing is working with our neighbours. So we work closely with South Yorkshire, with Staffordshire, and with other partners across the Midlands, so that we are focused on working on the right things together, and we're getting a lot of value from that as well. So we're learning from each other about how to implement and definitely implementing that. So yeah, absolutely collaborative working, so that the patients experience the same services.
That's great, Maria. I think you've answered Val's question, which was, will Joined Up Care Derbyshire be linking with Staffordshire as well, as UHDB has a foot in both camps? So
yes.
I think you've covered that.
Yeah, we absolutely don't want patients who are on those borders and are both accessing Burton Hospital to have a different experience, and we're working really actively with the Staffordshire system.
Peter, would you like to unmute your microphone? I think you wanted to ask a question. You've got your hand up.
Yes, I wanted to ask about the integration of blood test results, the notification of to patients as part of a patient-initiated follow-up system. At the moment, a referral for a blood test is commonplace as a basic diagnostic tool. But then and the results go back to the GP. But if in fact there's nothing untoward, the patient may hear nothing on a no news is good news system. But really, for the patient to be empowered, it's necessary to have an indication of, a negative result, nothing to worry about. Otherwise, you're left in limbo.
Yeah, absolutely. So that particular issue, we've been working really closely with primary care on, not just because of the patient-initiated follow-up, but because of the wider, both improving the patient pathway, but also making sure that you can access things in services in the right way. So we've been working really closely with primary care to work out across each different pathway where is it best to access the various diagnostics. So, for example, if we were changing the hospital service and offering you a non-face-to-face appointment, but you needed a blood test to go alongside that, what we wouldn't want you to do is to have to come to the hospital anyway for a blood test, because that's an unnecessary appointment. So we've been really working closely with our community providers and with primary care to say, if you don't need to be seen face-to-face in the hospital, how can we let you access your blood test in the community or in primary care? The test results coming to you is a new one for me. That's not necessarily been raised with me, so I can definitely pick that up and we can have a look at can we improve that. One of the things that we are working to try and also progress in patient-initiated follow-up is a wider patient portal. So that would offer you access to your hospital appointments, but it would offer you access to hospital letters, and potentially what we want to do for the future is to use that portal to do some of the self-monitoring and self-management. So that portal might be a route for the future through which we could make sure that you could access the relevant diagnostics and tests. So I can definitely take that forward. So I can look at whether there's something we can do right now, but that's definitely an ambition to improve from the future so that you can see all of the information relevant, whether that's diagnostic tests, hospital appointments, all of that together.
Thank you, Maria. And Luke, Michelle has asked, and I know this doesn't apply to anybody on our call today, what happens if there's a needy patient who perhaps asks for appointments too frequently?
Yeah, so just before I mention that, I just wanted to add in, just following the portal, what Maria mentioned. Again, the portal for electronic letters, that would only be for people who are wanting the electronic letters as well. So paper letters would still happen. So just to reassure you. Regarding whether patients would frequently kind of keep using the patient-initiated follow-up, again, this comes down to kind of clinician discretion. So we have had this conversation when we were first implementing patient-initiated follow-up, and actually some services were previously offering a similar type of follow-up, a kind of an open appointment, but with less structure of the letters going to GPs and kind of formal timelines and things like that. So again, the process will not necessarily change significantly. So if we have someone who kept requesting an appointment, but it wasn't appropriate, then the clinician can decide whether the patient should be on a patient-initiated follow-up or discharged. So again, it's that joint discussion with the patient to make sure they understand the use of patient-initiated follow-up. But also just remember that patient-initiated follow-ups come with a timeline as well. So if that timeline has passed, then it may require a new referral into the service.
Okay, Luke, and just following on from that, how will you ensure that patients understand what they need to look out for? So when they need to re-access, if it's appropriate?
Yeah, and again, that's the clinicians. So when they're having these conversations and making these joint decisions with the patients, they would then be giving advice at that point to say, okay, so just look out for this, this and this, and please come and access the service, obviously, if you see any of this. that's how I use it myself as a clinician as well. So I try to have very detailed conversations about kind of what's appropriate to come back with. And often that's having the conversation with a clinician who is very specialist in that area, which can offer kind of more specialist advice than potentially the GP can.
Thank you very much.
Sorry, Peter,
Maria.
just on that, I just wanted to add that we see this as a real benefit for the patients, because if you do have a worry, we want you to call us, and we could possibly, you know, if there is nothing, we can quickly reassure you, maybe through a quick telephone or video consultation, and we would much rather have that than have you have to go back to your GP, be referred in again. You know, we want you to re-access the services, so and to be able to reassure you, hopefully really quickly. So yeah, please don't worry that this means that you have less access. We hope it means that you've got more access when you've got a worry.
We've had a question from Melanie, who says, if a patient receives an outpatient clinic appointment but feels that a non-face-to-face appointment would be acceptable, can the patient initiate or request that?
Absolutely. If you have received a face-to-face and you'll have a contact number in there, please get in touch with us and we can have a look at whether the clinician feels it would be appropriate to run that. And there might be a reason why the clinicians decided to see you face-to-face rather than via a non-face-to-face route. But definitely ask that question. And we're actively encouraging patients who want to have a video consultation rather than a telephone consultation to ask for that, and we're looking to extend that. We really want patient choice of offer on how you would like to be seen, balanced with the clinical perspective of what's required in terms of clinical decision making.
Thank you very much. And Peter, I know you've had I'm trying to do it in time order, so I am sorry, people, if you feel you've been missed. I'm working my way through them. Peter, did you want to unmute your microphone? I think you wanted to ask a question.
It's Richard, I think.
Oh,
I think
Richard,
still
sorry.
gone. Yeah, no, you're okay. It's Richard Smith, please.
Right. Okay. Oh, it's me.
Hi.
So the question. Go on. Right. My question is about feedback. In a few minutes, I will be getting a parcel from an online supplier. A few seconds after, I will be asked what I thought of the delivery and the product inside the box. I've never yet been asked about my services from the NHS. How on earth are you going to plan services when you can't get feedback from the people you're delivering the service to? And my screen is full of statistical information saying how wonderful you are based on data which is slightly suspect. Sorry, but
All right.
you know,
yeah.
I think you're living in, well, let's say in yesterday's year.
All right. Thank you, Richard. Can we just ask Maria and Luke to comment about how we do, I mean, I know as somebody who rolled out the friends and family test, that is something that is offered to every patient, but I'll just pass over to Luke and Maria and let them comment to how we do collect feedback on patients' experiences.
So from a face-to-face appointment basis, as Katie said, we had the friends and family test. So after every face-to-face outpatient appointment, you would be given the option to provide us with feedback on that. And we do actively, across all of the trusts, look at that and use what patients are saying to inform our future improvement programmes. Video is really brilliant for us, because at the end of every single video consultation, you would have exactly what you've just described about a patient feedback. So you go straight from the end of the consultation into a really quick, short opportunity to feedback. And we've got some really brilliant data, which is exactly what we presented to you today about what our patients are saying about video. Telephone is an area that honestly we've really struggled with, and we're still wrestling with that, because when we put the telephone down, to be able to collect that information and be able for you to be able to feed back to us is not as easy. So we've been working on that and having a think about how we can collect information on the telephone side of things as effectively as we really can through the video. I don't know if Luke has anything you want to add about that.
Nothing in particular. I think you've covered it all there, Maria. And again, I would just reassure that if again in clinic when I'm seeing patients face to face and they want to provide feedback, then we can do that in a paper form as well, so it doesn't have to be digital.
Thank you very much. I'm just very conscious of the time, and so firstly, can I apologise to all the people whose questions are lower down and I've not got to yet. So I really do apologise to that. I'm also going to thank Richard for not mentioning his online supplier, because I know we're not supposed to promote anything, so thank you for that. I wanted to thank Luke and Maria, who've attended the session today. I'm sure, as you can imagine, they're both very busy with this rollout and looking at the way to do that. So thank you both very, very much for taking the time out and attending. Just to reassure everybody today that every question that you put in the chat box, we will answer. We work through with Maria and Luke, and we provide a full response to the questions. So if we've not covered it today, once Miriam uploads everything onto our website, you will be told that the material is now up there, and if your question wasn't answered, there will be an answer to that question for you to read at your leisure. Thank you to everybody who's joined us today. We do appreciate it. It's a lovely day, so we're very pleased that you took the time out. And we also want to say that our next session is on the 16th of April. That's a Friday, and we will be talking about the vaccine rollout in Derbyshire, about where we've been delivering the vaccine, what our take-up has been like, where we're seeing that people aren't coming forward, what are we doing to try to address that. So just everything related to the vaccine will be discussed on the next session. As always, there'll be more information about that, and we'll make that available. So thank you again, Maria and Luke, for coming today. Thank you to everybody else who has attended. Thank you for all your questions. We will get responses to you, and please go and enjoy the rest of the day and make the most of the sunshine. And we hope to see you again in April. Thank you very much indeed for your time.
Thank
Bye.
Thank you.
Thank you.
Bye.